Do you want to connect with clinicians, partners, investors, and experts who can speed up your scale-up in health tech? Our hands-on mentorship, guidance, and the program's suite of benefits can help you navigate the path to commercialization like the insider you'll soon be. To apply to be a Rosenman Innovator, go to rosenmaninstitute.org. Applications are open through April 12th.
There's no appreciation in the care delivery right now on understanding that there is a diversity of patients. There are patients who have unique health histories, unique needs, unique characteristics, and they should be treated in a way that is relevant to them. And that is, the big challenge of healthcare.
And now, from San Francisco and the UCSF Rosenman Institute, the Health Technology Podcast with your host, Christine Winoto.
Our guest today is Zeeshan Syed, CEO of Health at Scale Technologies. Health at Scale uses machine learning to provide precision care delivery. Their mission is to help patients find the right treatment from the right provider at the right time. Zeeshan's story begins with his time in academia. He was formerly a clinical associate professor at Stanford Medicine and an associate professor with tenure in computer science at the University of Michigan. After his father suffered a silent heart attack that might have been mitigated by proactive care, Zeeshan pivoted to impacting real-world outcomes by starting Health at Scale. He aims to improve patient outcomes through machine intelligence. Here's our conversation. Well, welcome, Zeeshan. Thank you for joining us this morning. It's Friday, we're recording here, and 2021 seems flew by already. I thought it would be fun for our audience, listeners, to hear about your background. You have quite an interesting background before you even start this new journey or this adventures. You started in academia, tenured, and then jumped ship. How'd that go about? What was the process and what prompted you to make that decision?
So Christine, thanks for having me on this podcast. For me, I started out many years back, I guess, by my academic career at MIT, got my bachelor's and master's there in computer science, finished in 4 years, and then decided that I would do many things with my life except for get a PhD. So I raced out, from Boston to the West Coast, took up a job here in the software tech industry. And then...
When was this?
This was back in 2003. So
okay, right after the bubble burst.
Yes, right after the bubble burst. It was an interesting time. I joined MIT when everyone was doing computer science, and then the bubble burst, and a lot of folks decided to gravitate away. But for me, I'd really been doing. I was working on AI and machine learning technologies that focused on healthcare at that time. Had done some interesting work, really enjoyed it. So, just decided to continue pursuing that.
Were you always when I think about computer science, most people think about Apple and Google. I mean, of course, that time Google is there already, but healthcare is not something that usually come first in people's mind when they study computer science. And what prompted you to go that direction? And what project were you working on?
So for me, what attracted me to healthcare as a freshman at MIT was, I wanted to go to medical school, and then I got into MIT and I said, hey, can't turn MIT down, and decided to join. And everyone was doing computer science, so decided, if the wisdom of the crowds was pointing in that direction, I should follow suit as well. And jumped right in and really enjoyed it. And sort of being able to do research in healthcare by applying AI and machine learning at that time brought the best of both worlds together. So started working on that, found an ally early on in John Guttag, who was the chair of computer science at MIT at the time. Started working with him, and under his mentorship, really sort of got very interested in how do we drive more impact through machine learning and AI in healthcare. When I finished, there weren't many opportunities at that time in the AI machine learning space. Right. It was still back in 2003. Yeah, so I ended up coming out here, took up a role at Oracle, was part of the team that was working on their server technologies. and sort of decided that that was the end of my academic career. I remember having a conversation with John at the time on the 5th floor of what was called LCS at that time, the Laboratory for Computer Science. They've rebranded it since as CSAIL, and he was sort of standing there, right next to my desk saying, you should really stick around and get a PhD. And I told him, gosh, looking out at another 6 years in school, that seems like a terrifying prospect.
So you were in Oracle. Was Oracle in the healthcare space at that time, or?
I was not working on healthcare at Oracle at that time. But for me, one of the things that happened was I think I was about 6 months in, and I got a call in the middle of the night from my uncle, who's a surgeon, and he calls me and he says, "Hey, your father's had a pretty bad heart attack." And the challenges in that case were, my father was diabetic, so he had what is often called a silent heart attack, where you don't feel the stereotypical symptoms of chest pain and the kinds of things that make you go into, get medical care. So he sort of, dismissed it as flu, and then by the time kind of, it was clear that he had a heart attack, there was a lot of, damage done to his heart. And for me, that was I would say, a particularly frustrating experience because, this is not something that is uncommon in the least. There are about 1 million heart attacks in the US each year. Many of the patients who have heart attacks have a history of diabetes as well. And for me, it was very frustrating that you have something that happens over and over again. And there are settings where if you get a patient into the hospital at the right time, the common statement is often, time is muscle. That if you get someone in quickly enough, you can save a lot of heart muscle and, help them recover or not have as severe, kind of lifetime damage to their heart. And we have, the situation where if we could get a patient the right care at that time, it would be life-saving, and certainly, lead to a completely different, sort of functionality and experience going forward for the patient. And we have this happen, millions of times, or across the world each year, and we haven't yet figured out how to improve that opportunity by matching patients and understanding and, ideally predicting or at least even detecting that something like this is happening. So I decided to finally go back and get my PhD because I felt that this was something that I wanted to throw myself hard at. So, called up my advisor, John, and I said, "Hey, you were right. I was wrong.
Back.
I'm coming back." And then ended up going back to MIT to this, it's a strange little program that they have. It's called the Health Sciences and Technology Program, which is a collaboration. You get admitted simultaneously to both MIT and Harvard. So in my case, I studied computer science at MIT, got a PhD there, spent 2 years at medical school at Harvard Med as well. And then when I graduated, I was very excited by the work that I was doing. A lot of my PhD research was focused on this question of how do we bring the kinds of data that is hard for humans to analyze, either because it is very high dimensional, so there are many, many, many different things that need to be factored in, or it's data that is collected over a long period of time. And how do we bring machine intelligence and artificial intelligence to really use this kind of data across thousands of patients and come up with ways in which we can improve care delivery? And specifically, my focus was on trying to understand if we could look at patients and identify who's at risk of sudden cardiac arrest as a way to match those patients to prophylaxis that could be helpful for them and could reduce that risk or prevent it from happening. So this time around, when I finished with my PhD, decided I would really go down the academic route. Went to the University of Michigan, which is fabulous place because it had a very strong medical school as well as an exceptionally strong computer science department and sort of broad strength across the disciplines, which for me was important as someone who was doing interdisciplinary work. And was at the University of Michigan for I think about 7 years. Ran a lab there which was focused on this question of how do we improve care delivery through machine intelligence. Received a bunch of different awards from the National Science Foundation, the American Heart Association, other places, and got tenure there at the end of it and moved out to Stanford for a few years. But I would say that at some point, my midlife crisis was getting on a call with John and saying, hey, we set out as a freshman back, in the day when I started, and then as a PhD student. And we really haven't had the kind of impact that we should have been driving. So we decided that we would start a company. And we basically went hard after Health at Scale, had a couple of other colleagues join us, Mohammed Syed and David Gadak from MIT as well. and went hard after really saying that we want to reinvent healthcare in a way that brings real sophisticated machine learning that understands the patient, doesn't really just focus on the notion that all patients are alike and we should have like the same cookie cutter ways of treating them and managing them and informing them of information about healthcare, but really come up with healthcare delivery that is hyper relevant, customized for them, understands them, and identifies what is the best way to deliver care for them individually at that moment, and sort of focus on that. So that's been the genesis in many ways for Health at Scale. Is kind of
Is this something that you've been working on through your professors and a PhD? You've been thinking about this areas for a long time, and then say like, you know what, there's a lot of there that we can create something that can make an impact instead of just being a research and produce journal paper.
Yeah, I mean, I would say that, so I ended up actually resigning my faculty positions. I jumped right in because this is something that I feel very strongly is the way to drive impact. And for me, one of the things that was important for me, and also, has been important for John and Mohammed, who also have faculty appointments, is, this question of how do we drive real world impact by taking the technologies that we believe are profoundly helpful, engineering them to operate at scale, deploying them with an understanding of the clinical operational challenges, and then essentially operating them, deploying them, running them, productionizing them in a way that ultimately we do drive longer, healthier, happier lives. I would say probably, for me, the biggest thing is I've written a lot of papers, given a lot of talks, but actually seeing real patients go through our system, have improvements in outcomes, that is a feeling that, I've never got in anything else that I've done.
Yeah, I think sometimes working on what you're doing is that, you got the feel of being a doctor without being a doctor, because you got to see the impact that you make on a patient. So it's interesting that, everybody, when you start a company, are academia, and oftentimes, at least, where we are at UCSF, when we have academia starting a company, usually is the graduate student or the postdoc who drive it, and they still stay in academia. And what would be, what's the lesson? What's the difference on running a lab versus running a company? What can you, what skill set the knowledge that transfer to running a company from running a lab in academia? I'm just trying to give some light about, what was the surprising thing when you see, how different it is from being in academia?
So for us, maybe the differences are, different than other companies might be, because, we very much focused on having Health at Scale be a high intellectually, sort of really focused on research side of things kind of a company. So we have a very much an academic flavor to things, which is perhaps not surprising because that's where we come from. But we've created a culture where, research is very important to us. Coming up with innovation is very important to us. We recruit very selectively and really sort of focus on bringing on board individuals who have, deep foundational understanding of AI and machine learning, have a real passion for healthcare, have, strong software engineering skills. We have clinical folks on board, like, Mohammed that I mentioned, who not just has an MD and is a practicing physician and on the faculty at Michigan, but is also a PhD in AI and machine learning. So we've, I think, for us, the biggest difference that I would say from academia to industry, and one that I often joke around with the people that I talk to is, in academia, you would work with students and the students would leave after they got their masters or PhDs. At Health at Scale, we've really been able to bring some of the most talented people together for the long haul. And we're working together on problems that we think are foundational problems in healthcare. How do you help match patients to providers? Something that is, it's just broken right now. If you kind of look at how it's done right now, you can look at consumer ratings or word of mouth. There's really no good structured way of matching patients to providers. How do you predict risk in a way that you can really inform personalized, targeted outreach to patients, and at a point where they are ahead of having their heart attacks and other things that will, sort of inflict a lifetime or burden on them? How do you prevent those things from happening? How do you help inform the treatment choices? How do you reduce the fraud, waste, and abuse. So we've really been able to focus on bringing together a phenomenally smart, talented, passionate, creative set of individuals together to take on some very, I would say, foundational problems in healthcare. And I think that for me is a big difference. Is we've really been able to build an enterprise in a way that I look forward to working with the folks that I have around me, for the years to come in the future.
Yeah. No, you get a chance to develop them and let them grow, and then yet they're still staying within the organization rather than just graduated.
This podcast is sponsored by Brown Rudnick's Global Life Sciences Group, a team of legal professionals that help life science companies, lenders, and investors around the world turn good science into good business. Learn more at brownrudnick.com. This podcast is also sponsored by Canon Quality Group. Canon Quality Group has been helping medtech startups set up quality management systems for over 10 years. If you're unsure when to get started with quality management in your startup, turn to the experts at canonqualitygroup.com.
So maybe this is a good time to, you kind of touch up on it a little bit about health at scale. Can you tell us, what does health at scale do, and what problem are you guys solving, and why is that so impactful?
Sure. So we are focused on what I would describe as precision care delivery. And what I mean by that is there's been a lot of discussion about precision medicine. And precision medicine, at least as I would, kind of truly describe it, focuses on customizing the development of new treatments for patients, often focusing on their omics data, their genomic, proteomic, metabolomic data. Our focus is not so much on developing new treatments. We're focused on delivering treatments. And for us, precision care delivery, which we see as a counterpoint to precision medicine, really focuses on how do we customize the delivery of treatments in a way that really is, hyper relevant, deeply personalized, at that point of time, the best, sort of optimal way that we should be thinking about delivering care. That is our mission. And it's born out of an appreciation that if you sort of take a step back and look at how the practice of medicine is done, in many cases, we are looking to really treat and deliver care for an average patient. We have a notion that providers are either all good or all bad. You sort of often come up with, 5-star ratings or 1-star ratings, but, there's a notion of, what works is, something that works for everyone or doesn't work for anyone. If you look at treatments, we have drug trials where half the patients get the drug, half the patients don't get the drug. If the patients that get the drug do better, great. We should go ahead and give this to everyone. Same thing with, the way that we right now are trying to outreach and manage patients is if patients go to the hospital many times or go to the ER many times, that's a group that you should be focusing on. There's no appreciation in the care delivery right now on understanding that there is a diversity of patients. There are patients who have unique health histories, unique needs, unique characteristics, and they should be treated in a way that is relevant to them. And that is, the big challenge of healthcare. So we have been focused on dealing with these challenges because if you look at the stats, they're profound. We found that, in our look of the data, about 80% of patients are not matched to providers that we think would be individually well suited for them. And I'm not talking about the best provider. I'm talking about the fact that they're not even matched to one of the top 5 or 7 providers in their local geography that would be best matched for their unique health conditions and needs.
When you say about, you're matching them with the right provider, is based on their overall condition that you found the right provider who understand all their comorbidity? I mean, what do you mean by that?
Yeah, so there's a lot to patients. There is, obviously their comorbidities matter. The kinds of, sort of encounters they've had with the kinds of, complaints they've had matter. There's the drug history that matters. There is, the family history that matters. There are the social determinants of health, information from, physiologic measurements and, sort of other data about, free text notes. And, there's a lot of information that really defines who a patient is. I would say there are tens of thousands of attributes for each patient. And, our focus is on matching patients to providers that are well suited with a full understanding of that patient. A lot of what's done right now, if you look at the way this question of matching patients to providers has been approached is mostly it's ad hoc. A lot of it is based on word of mouth.
And if their panel is open.
Sorry?
And if they're taking new patients.
If they're taking new patients, then there are, kind of consumer ratings. There are reputation-based rankings. There are, kind of process-based things, there are volume-based measures. But no one really gets to the question of, hey, for me as an individual, who is likely to improve my outcomes?
Mm-hmm.
And that's sort of been the focus for us. And that is, one of the things that we work on, in addition to matching patients to providers, we've spent a lot of time looking at this question of moving beyond, outreach that's focused just on patients who've had high past utilization.
Mm-hmm.
There's been a lot of literature, including research that came out of MIT that was published in the New England Journal of Medicine last year that showed that aggressive outreach focused on patients who've had a lot of ED visits and hospitalizations in the past is a little bit like trying to do things after the fact.
Mm-hmm.
You can't really claw back comorbidities and damage. It's better to get ahead of them. So that's, the other focus for us is how do we identify a patient who might be relatively healthy today, but is likely to have an outcome or a trigger that is going to completely change their health going forward. And how do you get ahead of that and keep them healthy for as long as possible, as opposed to try to claw back things after the fact once they've happened?
So I'm trying to understand is that if I were the patient, through the AI program, you match me with the right provider. But I'm just thinking, maybe me being naive, my hopefulness that all the providers, they got, standard medical school training. And why is that me matching with Dr. A versus Dr. B matters?
I think it depends on various factors. Some of it matters based on, different patients have different needs. So, you might have a provider who has seen more patients like you, has more experience with patients with the kinds of conditions that you have.
Mm.
They might have, through their residency or fellowship, developed a better appreciation dealing with the kinds of challenges that you might have as a patient. So that's one. We certainly appreciate that the way patients and providers communicate has a bearing on outcomes. So it might be that some people like providers who communicate one way, another patient might like a provider who communicates differently. So there are variations that arise from that. There are variations, especially when you get into, diagnostic versus more procedural things. There are differences based on, how well, some people might be better at diagnosing things. Some people might be better at the procedural side of things. So these are just a few examples, but there is a lot of variation that exists. And our focus is on saying that, there is variation. Let's understand that variation and then identify which providers are well suited to a patient like you.
Mm-hmm. So I know, like for your technology, who is paying for the service and why they should pay for that service?
So our focus is entirely on improving outcomes. And by improving outcomes, we work right now with some of the largest payers in the country, with some of the largest at-risk providers in the country. And we also work with employers. Those are the three organizations amongst many that we feel benefit from better outcomes for their patients.
Mm-hmm. And so I know that you get funded from Optum, a large chunk of money. I'll ask you more of that question. So obviously, this is definitely an interest for them. What kind of evidence base that you have to show, and how do you get there, and how far along are you in showing that?
Yeah, so we've recently published a couple of peer-reviewed studies, one in the American Journal of Managed Care, which showed that we were able to, with very high accuracy, identify patients who are at risk of severe respiratory infections, which is something that we believe is very relevant in the current era where, as we talk about flattening the curve, and it's a broad problem, it is very important to really focus on patients who are at highest risk of severe respiratory infections, that will likely get them into an ED or an ICU, and really focus on reaching out to those patients, having them switch to home delivery of meds and home delivery of groceries and other things that could be preventative for reducing their exposure. So we had a paper in the American Journal of Managed Care that talked about that, and also talked about also showed very strong results that we were able to substantially, in the post-acute setting, identify skilled nursing facilities that were associated with a significant reduction in, again, respiratory-related readmissions back to the hospital. So, and then more recently, we had another peer-reviewed paper in the Journal of Medical Internet Research that described that matching patients to providers using machine learning offers a substantially greater opportunity in terms of reducing ED visits, hospitalizations, and total cost of care compared to a pretty broad spectrum of reputation-based rankings, consumer ratings, volume-based ratings, and other things. So we have some peer-reviewed publications. We obviously have a lot of other results, both from customer-facing as well as internal studies that we have conducted that fairly convincingly shows that this focus on personalizing care delivery and personalizing care delivery in an intelligent way that is proactive and outcomes-based has a substantial ability to improve outcomes, and by improving outcomes, drive cost reductions for organizations that are managing these members.
Yeah, so which makes sense why the payers and employers are the people who are interested in your technology, because they are the one who has to pay for all the services. Tell us more, so the funding that, congratulations on getting that funded. You have Optum who, invests solely, I guess. And tell us the process, how, a lot of people probably want to get some investment dollar from Optum. How do you get there? And also having one investor, was it something that there's also, people always say, why do you need one? You don't want one investor, you need more than one investor. I mean, walk us through some of your thought process.
Yeah, so I want to actually go back to one of the points you just made about the insurers and the employers. I actually think that the work we're doing, the constituent who really benefits the most, and that is the one that we're focused on, is actually the patient.
Right.
Because ultimately, if you drive better outcomes, that, having seen that in my father's case firsthand, how a care decision or, timely care can impact things in a substantial, kind of life-changing way, it makes me appreciate that better outcomes, make a world of a difference to patients. And not to mention just the outcomes, better outcomes also translate into lower copays and have a financial bearing as well. So I would say that, the work that we're doing is something that fundamentally, I think the patient is at the center of it. And then there are obviously enterprises that manage the patient that focus on it. But, our decision to start this company, and sort of, move away from academia to jump right in was entirely driven by a desire to kind of, do the best good that we could to the patients. And that's kind of first and foremost for us.
Right. No, I totally agree. I think that's, I had to say, I have not met any entrepreneurs whose priority is not the patient. And I think that's what drives all of us, right? I always tell people, if you want to make money, there's so many other industries that you can do it much faster. And I don't know about easier, definitely faster than being in a healthcare, I think, for that. So I think we're all passionate about improving life. And, people have a lot of personal story. That's why they are so passionate trying to solve this problem.
Yes.
So, I mean, going back to your father's case, for example, and had he had a precision delivery, he would have a better chance of, having less damage to the heart. Walk us through, if he had go through the Health at Scale program, how that would impact him.
Well, so, and I'll sketch out, the utopic vision of where we want to go, because I really think that, we should fundamentally change how healthcare is delivered. There's patients are not happy with the status quo, and I think that needs to move. So for us at Health at Scale, first and foremost, we should have identified his rising risk. He, knowing everything that I do, with sort of his health history and his conditions, he was high risk. He should have been managed more proactively. for being at high risk of having a heart attack. And by management, I don't just mean sort of all the diagnostic kind of workup, but also informational. Letting someone know that, hey, you're diabetic. If you have flu-like symptoms for an extended period of time, do get that checked out, because sometimes an MI can manifest in that way. Mm-hmm. So first and foremost is what I would describe as intercepting high-risk cases, and then understanding them and informing them of things that are specifically relevant to them at that point of time. Mm-hmm. Then there is a second piece, which is matching them to a provider that is likely, again, with an understanding of their unique health history and health risk profile, able to manage them in a better way. So that's the second piece. The third piece would be monitoring. Right now, I think we're finally starting to get to the stage where we can actually engage patients and monitor them continuously. And that's one of the challenges that, I think for the longest possible time, we've been in the setting where a patient, when they're in a hospital, the patient is very well worked up, and then they just, sort of disappear into this black hole where you don't know what's happening with them. And then, the only time you see them again is when something has gone wrong. And I think that continuous monitoring, and especially in my father's case, if there was a way that you could be capturing his heart rate, you could ideally be capturing his ECG. That would have been a transformational, foundational, difference in what happened in his case. So that monitoring aspect is important, and that goes back to the interception and the provider navigation. That in a patient like him, I would have hoped that someone would have said, "Hey, you should have something on you that monitors you persistently for these kind of conditions." And then there's the treatment side of things. When someone has an MI, they're generally have a lot else that's going on in terms of comorbidities. And how do you balance these things out? How do you deal with a patient that, if they have atrial fibrillation, might need to be anticoagulated, but they also have hypertension, which means that if you anticoagulate them, they're at risk of ischemic strokes. And how do you balance those kinds of conditions out, where you have patients where you have competing things that are happening and you need to, really try to fine line. And then finally, and this is not so much relevant to my father's case, but, there's the whole notion of waste and fraud and abuse, and how do you kind of deal with that? So I think across the spectrum, when we talk about, things that should be different, we should be better at, intervening earlier and reaching out to patients. We should be better at helping them find the right providers. We should be better at monitoring them consistently. We should be better at choosing treatments for them, and we should be better at, just dealing with processing all of the transactions that happen around that.
Yeah. So those are all the suite of services or capability that you guys offer right now.
Yes, that is something that we are focused on. We are, high level, and as we expand, we are continuously adding more and more intelligence to care delivery from end to end. At the moment, those are the areas that we are focused on. Largely, again, because one of the things that someone said to me back when I was in the Valley in 2003, and I think this is someone who was involved during the early stages with Google, and the statement he said was, "You should build things that you would want to use yourself." And I think that was spot on, because when I look at the set of items that I just described, it really is the things that I wish existed for me and my family. And that's why, I think that there are problems with chasing.
Yeah, no, that's good. And so where are you in terms of delivering this product right now?
So we have, been out now in the market for the last, I'd say, 3 and some years. We are deployed at scale, covering, millions of patients. So we are at a stage where I think, one of my sort of proudest accomplishments, in addition to building the team that we have, which, I can't say enough good things about, is, we have managed to, I think, take artificial intelligence and machine learning from hype to reality. We run some of the largest deployments in the country where real machine learning is being used in ways that are reinventing healthcare. So that's something that, we take a lot of, pride and joy in.
Yeah. So it's interesting because you mentioned the whole, everybody used it for a while. It feels like a jargon, machine learning, AI. And then you really ask the question of well, it's not quite machine learning. And I always, I think the challenge oftentimes with a lot of startup is getting the right data to improve your algorithm. And how do you overcome that when you just started?
Yeah. So I will maybe submit to you that the challenge is not getting data. Data is actually surprisingly easy to get now. Back in the early 2000s when I was a freshman, it was very hard to get data. But I think that really has changed quite a bit. I think the challenge now is getting the expertise and the talent. Because it really, if you sort of look at a lot of the machine learning that's being done, I don't really think that we have skilled practitioners of the art really focusing their attention on this problem still. And machine learning and AI, if we take a step back, is fundamentally an advanced scientific discipline. It's not the sort of thing that you can, sort of take 2 online courses and say, hey, I'm going to work on some of these problems. It really is something that requires in many ways, a deep apprenticeship, if that makes sense, of having worked on these problems with someone who, has experience, understood the nuances of it, understanding where the gaps exist, having the facility to bridge those gaps. And I think that's the basic challenge right now. It is, still, having sort of, individuals who have a real understanding of machine learning, have, a deep foundational theoretical understanding of machine learning, and then have experience on top of that, is I think the limiting factor. Machine learning talent is still hard, and in other industries, I think we've recognized this. If you look at the folks that Netflix is hiring, or Google is hiring, or Apple is hiring, they're really focused on top PhD students coming out of top schools. I think in healthcare, machine learning is not quite there yet, and that I think is the biggest challenge. Is not the data, but the people.
Is it because it's hard to compete with those people in Google and Apple to attract those talent? Why is it challenging to get those expertise? Do you need the healthcare specific machine learning expert?
So I mean, I think for us, we've been pretty good. We've actually managed to outcompete these companies. A lot of it has.
You have access to academia.
We have access to academia, and we have really been very selective actually in the people that we brought on board. But the reality is there's just not a lot of them out there. To begin with, that's the short issue. That a machine learning PhD is worth their weight in gold because there's so few of them that are produced each year. A machine learning engineer who has sort of a strong machine learning background and strong software engineering skills is worth their weight in gold, because a good machine learning engineer is very hard to find. So I think that's the issue, that we have this on the one hand a scarcity of real talent, and on the other hand I think that it's this strange situation that we're in, where not a lot of people I think are really pushing to say, hey, I want good machine learning. And my sort of statement there would be, if I had to go get a surgery done, I would really insist on someone who had trained for many years. If I had to get a bridge built, I would say, give me someone who's actually got a degree in civil engineering. But in healthcare, I still think there are a lot of people trying to do things in-house without the right, sort of experience. And that is the kind of, the counterpoint to not having enough quality people is the fact that, there are a lot of folks who aren't as skilled in these disciplines that are trying to do it in-house. And we have this funny situation where both of those, I think, need to move.
Mm-hmm. So I'm not asking, you're not the policymaker of the government. How can we increase the number of talent in, because I think that's the direction where technology is, right? And I think healthcare definitely can benefit from that. Because after all, our healthcare is, need a lot of fixing.
Yeah. So having been on the inside, at the academic side, I'm a strong believer that, we are still heavily underfunded with, promoting, college and sort of, PhD level education in, in this particular case for AI and machine learning in those disciplines. I forget what the rates are now, but when I was a faculty member, I think there was a 10% probability that if you wrote a grant, the grant would get funded. And that's the sort of thing where you really need to increase the ability of top programs around the country to train more students, and you really to invest in that mission, which I think is important. Now, that being said, I think those investments will almost certainly pay a dividend a generation down or 2 generations down. So, it's not an overnight fix. I don't think if we suddenly threw a lot of money at the problem, it would, sort of go away, because you want to obviously increase volume while maintaining quality. It's very easy to just award PhDs to a bunch of people, but you really need to make sure they have the right attention, care, rigor, associated with what they're working on. And it has to organically grow. But I think that, making sure that our, sort of universities are not starved for resources as they continue that mission to train more people is, I think, very essential.
Or maybe in the meantime, you can try to steal more people out of Google and Netflix. Try to convince them to solve healthcare problem rather than their problem.
Yeah, I mean, I can speak for myself. I think working on healthcare is, I go to bed happy and I wake up happy. It is something that is
really
worthwhile to work on.
Yeah, no. With that, I think I'm running out of time. It's been so much my pleasure to learn so much about you and Health at Scale. And congratulations on all the work that you have done. And looking forward to see what's next for you.
Thanks so much, Christine. Really enjoyed talking to you.
Okay, great. Thanks.
Thank you for listening to another episode of the Health Technology Podcast. We want to thank our executive producer, Herminio Neto, our content writer, Kelly Muscat, and our podcast engineer, Andrew Rojek. If you enjoyed this podcast, be sure to subscribe and leave a review. The Health Technology Podcast is available on all major platforms.